the effects of glaucoma extend beyond the loss of vision and impact patients physically, practically, and emotionally. Early and effective intraocular pressure reduction is a key factor in preserving long-term vision. But for many patients, monotherapy may not provide the IOP reduction they need. By stepping up to Ganfort today, you could help many of your patients on monotherapy reach their target IOP. Ganfort offers powerful efficacy with proven ability to lower and stabilize IOP for up to 24 hours. And a meta-analysis demonstrated that Ganfort offers additional IOP control compared to other fixed combination topical therapies. Ganfort offers the reassurance of an established tolerability profile. And Ganfort UD offers the potential for additional tolerability benefits associated with preservative-free therapy. Ganfort gives you and your patients the reassurance of one of the most prescribed fixed combination glaucoma therapies. Treat with power. Treat with confidence. Step up to Ganfort today. One powerful drop today could create a life full of possibilities tomorrow.
Ano ang glaucoma? Ito ay grupo ng mga sakit kung saan nasisira ang ugat sa mata. Ang ugat natin sa mata responsable upang tayo ay makakita. Bahagi ng ating mata ang fluid na tinatawag na aqueous humor na nagbibigay nutrisyon at tamang pressure sa ating mata. Ang paggawa at paglabas nito sa ating mata ay kontrolado. Magkaroon ng problema sa paglabas nito sa mata o nagkaroon ng bara sa daluyan nito, maaaring tumaas ang pressure. Ang karaniwang sanhi ng glaucoma ay ang pagtaas ng pressure sa loob ng mata. Dahil dito, namamaga at naiipit ang ugat natin sa mata na nagdudulot ng panlalabo ng paningin. Kapag hindi naagapan, ito ay pwedeng magdulot ng pagkabulag. Ang mga individual na may mataas na tsansang magkaroon ng glaucoma ay ang may mga diabetes, hypertension o alta presyon, sakit sa puso, at myopia o nearsightedness. Kasama na rin dito ang pagkakaroon ng glaucoma sa pamilya at habang tumatanda, tumataas din ang tsansa ng pagkakaroon ng glaucoma. Kadalasan, ang pinakaunang senyales ng glaucoma ay kawalan ng peripheral vision o panlalabo sa gilid ng paningin. Tila hindi nila nakikita ang mga nasa paligid kaya sila ay madalas na natatalisod, nadadapa o kaya nabubunggo. Maaari rin na sila ay nakakakita ng mga halo o maliwanag na mga bilog sa paligid ng ilaw. Kung napansin ang mga ito, pwede nang kumonsulta mga simptomas. Kapag lalo pang tumaas ang pressure, maaaring sumakit at mamula ang mata at lumabo ang paningin. Pwede ring sumakit ang ulo, mahilo at sumuka. Kapag naramdaman ang mga ito, agad-agad na kumonsulta sa doktor. May magagawa pa ba? Posible na hindi na bumalik sa dati ang paningin. Ngunit ang mahalaga ay mapigilan ang paglala ng sintomas at tuluyang pagkawala ng paningin. Dahil isa sa maaaring magdulot ng glaucoma ay ang pagtaas ng pressure sa loob. Kailangan itong lang para mas madali isipin natin ng tubig sa gripo, iniiwan din ang papunan nito. Katulad ng paggamot sa glaucoma at ang tumatapon ng tubig sa baso. Sa simula, maaaring bigyan kayo ng gamot ng inyong doktor. Pwede kayong bigyan ng pinatatak abis ng epektibo ito. Para kasi yung at may side effects kayo. Isang paalala, pagkatapos ipatak ang gamot sa mata, pumikit ng 3 minuto o dahan-dahang masahihin ang gilid ng mata. Sa tulong nito, titibay ang epekto ng gamot sa inyong mata. Bukod sa gamot, isa ring option ang laser treatment sa mata. Ngunit kung mas malala na ang kondisyon, kinakailangan na ang operasyon. Lahat ng mga ito ay mapapaliwanag sa inyong konsulta sa doktor. Tandaan, sa tulong ng maagap na gamutan, maaring mapigilan ang paglala ng sintomas at bumuti ang kalagayan ng inyong mata. Kung kaya't kailangan kumonsulta agad dahil maaring lumala ang sintomas at tuluyang mawala ang paningin kung hindi naagapan. Mahalagang alagaan ang katawan. Kumain ng masustansyang pagkain tulad ng gulay at isda, bawasan ang puro matatamis at maalat na pagkain, dalasan ang pag-inom ng tubig, at mag-ehersisyo araw-araw. Bantayan ang sugar at blood pressure at inumin ang maintenance kung meron. Sa pamamagitan nito, maiiwasan o makokontrol natin ang alta presyon o diabetes na maaari magdulot ng glaucoma. Marami pang lugar at selebrasyon ang inyong pupuntahan, mga anak at apong sasamahan. Kaya simulang gumalaw, kumonsulta sa doktor at ituloy ang tamang gamutan. Iwasan ang gulat mula sa glaucoma.
For many people, sight is their most precious sense. Yet the reality of glaucoma progression remains far too common. The effects of glaucoma extend beyond the loss of vision and impact patients physically, practically, and emotionally. Early and effective intraocular pressure reduction is a key factor in preserving long-term vision. But for many patients, monotherapy may not provide the IOP reduction they need. By stepping up to Ganforth today, you could help many of your patients on monotherapy reach their target IOP. Ganforth offers powerful efficacy with proven abilities to lower and stabilize IOP for up to 24 hours. And a meta-analysis demonstrated that Ganforth offers additional IOP control fixed combination topical therapies. Ganforth offers the reassurance of an established tolerability profile. And Ganforth UD offers the potential for additional tolerability benefits associated with preservative-free therapy. Ganforth gives you and your patients the reassurance of one of the most prescribed fixed combination glaucoma therapies. Treat with power. Treat with confidence. Step up to Ganforth today. One powerful drop today could create a life full of possibilities tomorrow.
Ano ang glaucoma? Ito ay grupo ng mga sakit kung saan nasisira ang ugat sa mata. Ang ugat natin sa mata ang responsable upang tayo ay makakita. Bahagi ng ating mata ang fluid na tinatawag na aqueous humor na nagbibigay nutrisyon at tamang pressure sa ating mata. Ang paggawa at paglabas nito sa ating mata ay kontrolado. Kung magkaroon ng problema sa paglabas nito sa mata o nagkaroon ng bara sa daluyan nito, maaaring tumaas ang pressure. Ang karaniwang sanhi ng glaucoma ay ang pagtaas ng pressure sa loob ng mata. Dahil dito, namamaga at naiipit ang ugat natin sa mata na nagdudulot ng panlalabo ng paningin. Kapag hindi naagapan, ito ay pwedeng magdulot ng pagkabulag. Ang mga individual na may mataas na chance ang magkaroon ng glaucoma ay ang may mga diabetes, hypertension o alta presyon, sakit sa puso, at myopia o nearsightedness. Kasama na rin dito ang pagkakaroon ng glaucoma sa pamilya at habang tumatanda, tumataas din ang tsansa ng pagkakaroon ng glaucoma. Kadalasan, ang pinakaunang senyales ng glaucoma ay kawalan ng peripheral vision o panlalabo sa gilid ng paningin. Tila hindi nila nakikita ang mga nasa paligid kaya sila ay madalas na natatalisod, nadadapa o kaya nabubunggo. Maaari rin na sila ay nakakakita ng mga hilag ng mga bilog sa paligid ilaw. Kung napansin ng mga ito, pwede nang kumonsulta sa doktor upang maagapan ang paggala ng mga simptomas. Kapag lalo pang tumaas ang pressure, maaaring sumakit at mamula ang mata at lumabo ang paningin. Pwede ring sumakit ang ulo, mahilo at sumuka. Kapag naramdaman ang mga ito, agad-agad na kumonsulta sa doktor. Posible na hindi na bumalik sa dati ang paningin. Ngunit ang mahalaga ay mapigilan ang paglala ng sintomas at tuluyang pagkawala ng paningin. Dahil isa sa maaaring magdulot ng glaucoma ay ang pagtaas ng pressure sa loob ng mata, kinakailangan itong bawasan sa pamamagitan ng una, pagkontrol ng produksyon ng fluid sa mata, at pangalawa, pagkontrol ng paglabas ng fluid. Para mas madaling intindihin, isipin na ang mata ay isang baso na pinupuno natin ng tubig sa gripo. Iniiwasan natin ang pagpuno nito. Katulad ng paggamot sa glaucoma, maaari nating hinaan ang lumalabas na tubig mula sa gripo o damihan ang tumatapon ng tubig sa baso. Sa simula, maaaring bigyan kayo ng gamot ng inyong doktor. Pwede kayong bigyan ng pinapatak sa mata o iniinom na gamot. Kailangan tandaan na may oras at may dami ang paggamit ng gamot. Sundin ang abiso ng doktor para maging epektibo ito. Bumalik din sa doktor sa takdang araw para matiyak kung may pagbabago sa inyong paningin at kung may side effects kayong nararanasan. Isang paalala, pagkatapos ipatak ang gamot sa mata, pumikit ng 3 minuto o dahan-dahang masahihin ang gilid ng mata. Sa tulong nito, titibay ang epekto ng gamot sa inyong mata. Bukod sa gamot, isa ring option ang laser treatment sa mata. Ngunit kung mas malala na ang kondisyon, kinakailangan na ang operasyon. Lahat ng mga ito ay mapapaliwanag sa inyong konsulta sa doktor. Tandaan, sa tulong ng mapigilan ang paglala ng sintomas at bumuti ang kalagayan ng inyong mata. Kung kaya't kailangan kumonsulta agad dahil maaari lumala ang sintomas at tuluyang mawala ang paningin kung hindi naagapan. Mahalagang alagaan ang katawan. Kumain ng masustansyang pagkain tulad ng gulay at isda, bawasan ang puro matatamis at maalat na pagkain, dalasan ang pag-inom ng tubig, at mag-ehersisyo araw-araw. Bantayan ang sugar at blood pressure at inumin ang maintenance kung meron. Sa pamamagitan nito, maiiwasan o makokontrol natin ang alta presyon o diabetes na maaari magdulot ng glaucoma. Marami pang lugar at selebrasyon ang inyong pupuntahan, mga anak at apong sasamahan. Kaya simulang gumalaw, kumonsulta sa doktor at ituloy ang tamang gamutan. Iwasan ang gulat mula sa glaucoma.
For many people, sight is their most precious sense. Yet the reality of glaucoma progression remains far too common. The effects of glaucoma extend beyond the loss of vision and impact patients physically, practically, and emotionally. Early and effective intraocular pressure reduction is a key factor in preserving long-term vision. But for many patients, monotherapy may not provide the IOP reduction they need. By stepping up to Ganforth today, you could help many of your patients on monotherapy reach their target IOP. Ganforth offers powerful efficacy with proven abilities to lower and stabilize IOP for up to 24 hours. And a meta-analysis demonstrated that Ganforth offers additional IOP control compared to other fixed combination topical therapies. Ganforth offers the reassurance of an established tolerability profile. And Ganforth UD offers the potential for additional tolerability benefits associated with preservative-free therapy. Ganforth gives you and your patients the reassurance of one of the most prescribed fixed combination glaucoma therapies. Treat with power. Treat with confidence. Step up to Ganforth today. One powerful drop today could create a life full of possibilities tomorrow.
Good afternoon, everyone. It's that time of the week once again, and we all know what that means, right? It's time for another interesting ITV episode. So, it is my privilege to welcome you to episode 20 of TMC ITV. I'm Dr. Nico Rogelio, and I invite all of you to join us this afternoon for another virtual learning opportunity. The glaucoma section of the Medical City Eye and Vision Institute invited one of its consultants to discuss the Xen stent implant and hopefully have a discussion about questions and queries when it comes to this surgical device. To begin our program, let's hear from Mr. Egbert Huson, the country manager of our sponsor for this episode, Allergan, for his opening remarks.
Good evening. On behalf of Allergan and AbbVie Company, we would like to welcome you all to episode 20 of the Medical City's ITV. And this would not be possible without the hard work of the ophthalmology department, headed by Dr. Vic Caparas, Chairman, and Dr. Gio Alejo, Chief President. For tonight's session, we would learn the tips, tricks, and techniques for Xen implantations. And this would be discussed to you by your very own glaucoma specialist and Xen master, Dr. Romel Bautista. Please feel free to ask him everything there is to know about MIGS. And just like any procedure, MIGS would entail a steep learning curve. And that is why it is important that we learn as much as we can for those who have tried the procedures already. And it is this main reason why we needed the services of a very good moderator. And for tonight, helping us facilitate is Dr. Nico Rogelio. Again, we have been in the business for more than 120 years, and this was when we were still part of Abbott Laboratories. In 2013, AbbVie was established just for the sake of creating more products, more research and development for more therapeutic areas. In 2020, the acquisition of Allergan was completed, and we expanded this innovation to ophthalmology. Again, our main focus is the patient, and helping you in partnerships like this really means a lot for us. Again, on behalf of the company, with Jaisal, our product specialist, Mike, our sales manager, and Alan, our product manager, this is Egbert saying that our mission is to create a world where the patient's vision would last a lifetime. Thank you very much.
Thank you, Mr. Huson, for that warm welcome for our viewers, and thank you to Allergan for teaming up with us to offer our viewers a segment that would be relevant to the times. Again, I'd like to remind our viewers that this week is World Glaucoma Week. Glaucoma remains to be one of the leading causes of blindness in the world. However, recent advances, both medically and surgically, have helped ophthalmologists manage our glaucoma patients better throughout the years. Now let's cut to the chase. One of the hot topics in glaucoma today is minimally invasive glaucoma surgery, or MIGS. And of course, one name that has been associated with this is the Xen stent implant. But really, how has the Xen implant changed the landscape in MIGS? To learn more about this, let us welcome our speaker for today, Dr. Romel Bautista. Dr. Romel Bautista finished his residency training at the Medical City, after which he did his glaucoma fellowship at Stanford University Medical Center. He has been an active member of the Philippine Glaucoma Society and is currently affiliated with the Medical City. He has performed a number of Xen stent implantations the past 3 years, and he has graced us today to share more about his experience with regards to this device. If you have questions, do not hesitate to type them in our chat box, and we will try our best to accommodate all questions during the Q&A session later on. Without further ado, let us now give the floor to Dr. Romel Bautista.
Good afternoon. Thank you, Nico, for that very kind introduction. And, before anything else, I'd like to greet everybody, all the viewers for today's EyeTV session. I'd also like to thank Department Chairman, Dr. Victor Caparas, who has been extremely proactive in pushing the envelope forward in terms of trying to perform or trying to advance our knowledge on minimally invasive glaucoma surgery. I'm happy to say that amongst perhaps maybe all the tertiary hospitals located not only in Metro Manila but in the rest of the country, Medical City has the most number of minimally invasive glaucoma device insertions, whether it be Xen or maybe the eye stent Gen 1 or Gen 2. There are other individual eye centers out there who do perform this procedure, but as a tertiary hospital, I believe the Medical City leads in the number of cases. So today I've been tasked to talk about the Xen Gel implant, the Xen 45 Gel implant, which I believe has changed the landscape of surgery for glaucoma because number one, of course, it's minimally invasive. As we will see later on, it is the level of efficacy and the ease of follow-ups and recovery time will be kept to a minimum. So as a background, minimally invasive glaucoma devices have been around for almost a decade now. Xen in particular has been FDA approved since 2016. And the way it works is that, as you can see from the slide, there are many different devices that have been developed over the decade. And some are implanted in the trabecular meshwork, such as the hydrous, the eye stent in general, eye stent, all of which we have used except for the hydrous. And these drain essentially into the trabecular meshwork and is therefore governed by the level of IOP drop is governed by the level of episcleral venous pressure. So we do not really expect very low pressures with these devices. Other devices that have been developed but approved and then eventually pulled out of the market are basically suprachoroidal space devices such as the CyPass and the iStent Supra. But for the Xen Gel Stent, it was designed to drain from the anterior chamber into the subconjunctival space, no different from the traditional trabeculectomy that we normally perform. So here, again, is a short slide showing you the three essential outflow pathways for MIGS: trabecular meshwork, subconjunctival, and suprachoroidal space. For today, we will be focusing mainly on Xen and its role in diverting aqueous fluid from the anterior chamber into the subconjunctival space. So the Xen 45 has been labeled as a trab killer, and in my opinion, it really is. As mentioned, it is placed subconjunctivally or subtenons, depending on the surgeon. It requires mitomycin C, the dosage of which varies depending on the surgeon. And it's more importantly, it's capable of lowering IOPs due to the absence of the episcleral venous floor, and therefore single-digit IOPs are achievable and are often seen post-operatively. Because it is minimally invasive, blood management issues may pose some issues in some cases, but not as difficult and not as prevalent as that we would normally experience in the usual or traditional trabeculectomy. Because of the diameter, the inner diameter of the Xen 45, which is 45 microns, hypotony is not really an issue as opposed to the traditional trabeculectomy. So what is a Xen 45? A Xen 45 is inserted, as you will see later on, either ab interno or ab externo using a proprietary injection system. It is made out of a relatively inert gelatin derived from porcine dermis, formed into a tube and cross-linked with glutaraldehyde. The dimensions of the Xen implant is approximately 6 6 millimeters. The diameter is 45 microns, hence the name Xen 45, and with having an outer diameter of about 145 microns. The usual indications for implantation of the Xen is, of course, you need to visualize the angle, so primary open angle glaucoma, pseudoexfoliation or pigmentary glaucoma. As you will see later on, we're able to place it, or we're able to implant it in eyes with failed trabeculectomy, having open angles and still viable conjunctival areas. Of late, starting, I believe, the year 2020, Xen implants have been used in pediatric glaucoma. Contraindications include angle closure, uveitic glaucoma, and of course, close-stage neovascular glaucoma. In selecting cases, normally in my clinic, normally implant Xens in patients who are essentially in need of treatment acceleration in the form of trabeculectomy. These patients are typically heavily medicated or medication intolerant or are already complaining of severe or profound ocular surface disease. It's also a good alternative for people with compliance issues, with documented progression, and when traditional surgery and recovery is undesirable. I also prefer to implant minimally invasive glaucoma devices, or in particular Xen, in patients with only one eye, simply because there's not much in the way of dissection, in the way of choroidals, in the way of vision drop, because hypotony is basically never an issue with this particular device. Choosing your initial patients or choosing patients for Xen implantation, obviously you need an ideal conjunctiva, good trabecular meshwork visualization on clinical gonioscopy. Choose a patient that has low cheekbones because the injector, as you will see later on, is relatively straight, and it will be very difficult for you to insert it inferotemporally or inferiorly, as the cheekbones interfere with the implantation or the inserter. A nasal speculum is ideal because the blades of the speculum typically interfere with the inserter. And of late, I've learned to shift from an inferotemporal approach to a purely temporal approach whenever I do ab internal insertions. The typical post-operative course is, prior to the surgery, I typically stop all topical medications approximately 2 weeks before surgical date and shift them to oral, if only to quiet the eye a bit, because as you insert the Xen later on, you will see that in a very inflamed eye caused by too many medications, bleeding is very difficult to avoid, and visualization can be very tricky at that point. So just to orient everybody as to how Xen is actually inserted, here's a short animation video. So the trocar, the inserter, is inserted, passes through ideally above TM to avoid bleeding. Go up and tent up the conjunctiva, leaving the Tenon's capsule below it. Deploy the device while applying positive pressure on the angle, and then withdrawing the device and allowing the Xen implant to basically drain fluid at the rate of about 2 to 3 microliters per minute. Immediately after inserting the Xen, as you will see in later videos, a bleb can easily be appreciated immediately after inserting. So this is a video of one of my earliest cases. Normally, we mark about 2.5 to 3 millimeters from the limbus. The 3 millimeter, the 2.5 or the 3 millimeter point is where your needle typically exits, and then the about 2.5 to 3 millimeters of the center will be posterior to that mark. So here's the video. We start off with injecting approximately 0.2 cc of 0.4 milligrams per cc mitomycin C mixed with a bit of lidocaine, approximately 6 millimeters from the limbus. That will be the antifibrotic component of this surgery. With a wet Q-tip or with a Q-tip, you can spread it around. An initial incision is made inferotemporally or temporally, which is where Xen device is inserted. But before that, I apply intracam lidocaine and sometimes a bit of myostat to constrict the pupil and make the view of the angle even better. And then we inject viscoelastic to stabilize the chamber. Here we're putting a bit of viscoelastic on top because we have a disposable Catena gonio mirror to be able to see the angle superiorly. A second small incision is made to insert a second instrument for countertraction. Sandro, power. Here we're inserting the Xen inferotemporally. This is the left eye. I'm using my left hand. Put the gonio mirror in place and aim for the top of the TM, not exactly the TM to avoid bleeding. Apply positive pressure, and once you've pierced that portion of the angle, you can pretty much apply positive pressure and push the needle forward or the inserter forward. As you cross Tenon's insertion, the bevel of the inserter, the gauge 27 inserter, should be visible immediately under conj when you can start to deploy. Deployment should be done with care to avoid flicking and malpositioning the implant. Once the device is deployed, then a gradual withdrawal of the inserter is done. Here, as you can see, I'm trying to move the Xen, which is placed subconjunctivally. I'm trying to apply, I'm applying the gonio mirror again to see that I have about maybe 1.5 millimeters worth of Xen implant inside the angle, as you can see right here. Again, we want the Xen to be free and mobile, and as you move the Xen around from left to right, the best way to confirm whether you are actually above tenons and under conj is the fact that if you move it left, it doesn't spring back to its original position. Left or right, for that matter. So here immediately you see a bleb forming. Some of it is obviously because of peritubular flow. It's quite a big bleb. As you can see, it's well elevated. It's not uncommon to have 260 degrees or even 360 degree bleb upon inserting the stent. The last part of the procedure really is basically purging the anterior chamber of viscoelastic using just BSS. So no machines are required. It's basically just a microscope and a few instruments. A good knowledge of your angle anatomy is obviously quite important. And here we have a nicely formed blood. And the case is complete. This is the traditional ab interno approach, by the way, where everybody started learning how to insert the stent. Over the years, as you will see later on, many modifications as to how to apply or insert the stent will be demonstrated. This is the Icomed Air Gel Technique, and basically the air gel technique starts off with a gauge 30 needle inserted subconj, wherein you separate the conjunctiva and the tenons by air and subsequently with gel. So here we use a 30 gauge needle. That's purely air, followed by a bit of viscoelastic, so that you have a very, very good separation between tenons and conjunctiva. It assures that the stent is very well placed in between those two tissues. So here, sorry. Host. Are you with me?
Hi, sir. Yes, I'm.
Yeah, so sorry, it stopped.
Okay, so if you have since we're having a bit of a technical difficulty right now, I just like to take this time to remind our audience that at this point, if you already have any questions or clarifications for Dr. Bautista, you can type them into our YouTube chat box, and we will get to them at the end of our session in the Q&A session.
How do I share my screen again? I click share. Are you on my screen?
We can see your screen, sir. We see the frame of the there we go, sir. We can see the video playing na po.
All right. Okay, so here we go. Inserting it. As you can see, the bevel of the needle is right under conj. This particular surgeon, Dr. Okane, stained the stent with the blue dye to make it more easy to visualize. That's why it was blue. And here, she's basically milking the stent, encouraging flow, purging the anterior chamber of viscoelastic. And the last part is the injection of the antifibrotic. A bit of rinsing and the case is complete. This is the one example of an ab externo technique, which I basically took off the internet. So here, traction suture is made at 12 o'clock. So this is a closed coj ab interno insertion. She starts off at about 8 millimeters backwards. And when she reaches about 2 millimeters from the limbus, she starts to dive down to create a scleral tunnel with the trocar. Takes a fair amount of pressure to get there, but you'll see the tip of the inserter in the anterior chamber. And once you see that, then you can start deploying the stent. Once the stent is deployed, the yellow part is actually the tip of the stent. There's a bit of heme going on, but that's usually self-limiting. Again, just to confirm that you're approximately 1 millimeter inside the anterior chamber. She decides to push it a little bit, maybe get about 1.5 millimeters in. And now she's priming she's applying the mitomycin C, pushing it backwards because we don't want the vascular limbus, and to ensure that the flow of aqueous is more posterior. Here, if you noticed, Dr. Ann did not apply any viscoelastic into the anterior chamber, so there wasn't anything to purge. This is a typical ab external approach, wherein we do a basic peritomy, a very small one compared to what we would normally do for a trabeculectomy. Mark about 2 to 2.5 millimeters from the limbus, and basically just insert the stent, tunneling it into the sclera through either tenons or through sclera. Whether you put the stent underneath tenons and cons or simply just under the cons is still up for debate, but the results are pretty much the same, except that this time there's a bit more suturing required. So essentially, obviously this is not a video, it's a screenshot, but you get the picture. It's pretty much the same as the previous video, except that this time the conch was open. So what happens when things aren't ideal? Typically, surgeons would needle, no different from performing a trab. And you do that by needling below and above the tip of the stent. But be careful and perform it with care because the stent can and will often fracture. Also, when needling, be reasonable with bleb elevation expectations. Whenever we needle trabeculectomies, the minute we puncture it, you see an immediate rise or an immediate vault of the conjunctiva and the tenons. But because the stent 45 releases aqueous in a very controlled fashion, be reasonable in your expectations as far as bleb height or bleb ballooning is concerned. I've also used a fair amount of post-operative 5FU, especially when I didn't, in the early days when I didn't used to stop all topical medications and shifted them to oral acetazolamide. If everything else fails, you can always do an open revision, which I will show you in a bit. So this is a case of perhaps maybe the worst open revision I've ever done. As you can see, this is all scar tissue, and obviously the yellow part is the stent. This patient took about several months to develop this gigantic scar and have his pressure start to elevate. So let's see. So careful dissection. I know it's stupid, I'm using the wrong scissors. But look at how big that fibrotic scar is. It's huge. So one last cut. And the fibrotic scar is gone. Because we're an open revision, sorry about that, Nico. Okay, because we are an open revision, I decided to put mitomycin using sponges. But look at this end. Many months after, it's still drained. And the only reason why the procedure never worked was because a massive fibrotic scar enveloped the whole place or covered the stent. But I'm happy to say that this patient recovered well in a simple open revision, and his pressures are now in the low teens, if not 11 or 10. Okay. I've also put several stents in patients who have had failed trabeculectomies. Here's an example of a fairly nicely vaulted bleb, although it's a bit ischemic, but the pressures are very well controlled. And I've got maybe, on gonio, I've got approximately maybe a millimeter and a half of stent inside the AC. And thank God this patient didn't have to undergo a repeat trabeculectomy, or more importantly, a tube, which would have destroyed a lot of conjunctival real estate. A simple stent implanted nasally did the trick for this patient. This is another case of a failed trab. If you notice over here, it's quite hyperemic. This is where the failed trab is. Again, fairly avascular bleb, not ideal, but with good vault. And gonio shows that I'm right above the PTM, perhaps maybe a little longer than what I would have preferred, but it's not touching the corneal endothelium, and neither is it touching the iris plane, and that's always good. That's ideal. So my personal numbers after over 30 cases, typical post-operative regimen for me is to give antibiotics for about a week and steroids for about a month, as opposed to the usual trabeculectomy. The IOPs that I've gotten ranges from single digits, 8, and the highest would be about 14. If it goes beyond 14, then I get a little worried, and I'm starting to think of perhaps maybe fibrosis or needling or having to revise it. The single-digit IOP, one-day post-op, appears to be a good predictor of long-term success, but not always. I've seen people who have had IOPs of 11 or 12 on day 1, and have remained that way for at least a couple of years. I've had one case of decompression retinopathy. I've had open revision in 3 cases. I've had one case of slit lamp needling, because I'm not fond of doing that on the slit lamp. I'd rather do an open revision rather than needle on the slit lamp, because you can easily fracture the stent needling it, especially when there's already heme. And I've got one case of conjunctival perforation, meaning to say the stent actually pigtailed backwards and perforated the conjunctiva, of which was repaired with a radial conjunctival incision and then replacement of the same stent. I do use 5-FU post-operatively in select cases. The amount of which that I use is about 0.15 cc. And I'm happy to say that after over 30 cases, none have needed meds or further surgical intervention. Bruce, do you have that video, brother? Bruce?
However, if we suspect that scar tissue has entirely enveloped the tip of the Xen, open revision may be needed. I first mark out the Xen and then perform a limited conjunctival peritomy very gently without damaging the Xen. Unlike in needling, I like to go straight for the Xen first, with my priority to expose and isolate the implant. There is a lot of adhesion by this time, and it is not easy to perform the dissection while avoiding damaging the implant. It is not uncommon to see a sock of tissue encasing the implant. What is useful to do is to first isolate the Xen together with the fibrotic tissue as a single complex by separating the adhesions from the conjunctiva. Once that's done, I take my time to tease away the tissue from the implant. This is not easy, as the tissue can be very stubborn and adheres to the Xen. The Xen also tends to bend easily, and it can be challenging to get counter traction as you're working on the scar tissue. But once you've done enough, you'll see the fibrous tissue rolled back like a loose sleeve around the implant, and becomes easy to completely free a good length of the Xen. When I do an open revision, I go a little further to check the internal opening of the Xen. In this case, I've actually found a strand of fibrin plugging the internal mouth of the Xen, which I easily removed with a Simcoe under intraoperative gonioscopic guidance. Now I test the Xen itself for patency. I do this by observing the beading of the aqueous at the tip of the Xen. Alternatively, I douse the area with concentrated fluorescein, and after a few seconds, a distinct enlarging clearing will form right at the tip of the stent. Should there be no evidence of patency, I flush BSS through the implant using a 26 gauge blunt cannula. In this case, you can actually see the blood and debris passing through the lumen of the stent upon flushing. Finally, I create a generous subcutaneous clearing around the Xen, apply mitomycin C sponges with saline washout before closing the conjunctiva. In summary, we adopt two approaches to reviving our Xens. When there is encapsulation and immobile Xen, we perform needling. But when fibrosis develops over the tip of the Xen, or where there have been multiple failed needling attempts, open revision may be needed. Thank you for watching.
Thanks, Bruce. That was another Xen colleague from Singapore who we constantly communicate with and exchange ideas when it comes to cases and difficult cases. His name is Dr. Brian Ang. He's worked very closely with the Allergan group and is one of the Xen masters in Singapore. So I know he's not here. I'll text him a bit later, but thank you so much for that video, Brian. At this point, I think the talk is pretty much done, and we'd like to open the floor for questions. Because, perhaps maybe a lot of you are a bit wary of adopting something very new as part of your surgical armamentarium when it comes to treatment acceleration in glaucoma.
Thank you for the very informative lecture, Dr. Ramel. I am sure many of you have questions after that presentation, and we will give you some time to think about them and gather your thoughts. To give you a clearer insight, we will be addressing some of the questions you have sent through the comment section of our YouTube channel, which Dr. Bautista will gladly get to at our Q&A session. Please also fill out the attendance sheet posted on the chat box of our YouTube link to have access to our previous episodes and to be informed of the next ones to come. Before we move on to the next segment of this afternoon's episode, let us watch this short clip prepared for us by our sponsor, Allergan.
For many people, sight is their most precious sense. Yet the reality of glaucoma progression remains far too common. The effects of glaucoma extend beyond the loss of vision and impact patients physically, practically, and emotionally. Early and effective intraocular pressure reduction is a key factor in preserving long-term vision. But for many patients, monotherapy may not provide the IOP reduction they need. By stepping up to Ganforth today, you could help many of your patients on monotherapy reach their target IOP. Ganforth offers powerful efficacy with proven ability to lower and stabilize IOP for up to 24 hours. And a meta-analysis demonstrated that Ganforth offers additional IOP control compared to other fixed combination topical therapies. Ganforth offers the reassurance of an established tolerability profile. And Ganforth UD offers the potential for additional tolerability benefits associated with preservative-free therapy. Ganforth gives you and your patients the reassurance of one of the most prescribed fixed combination glaucoma therapies. Treat with power. Treat with confidence. Step up to Ganforth today. One powerful drop today could create a life full of possibilities tomorrow.
Now, ladies and gentlemen, since the 1980s, the Philippines has always earmarked the second week of March as a time to celebrate and commemorate Glaucoma Awareness Week. This puts into context our episode today, which serves as the TMC Eye and Vision Institute's small contribution to this effort. Glaucoma has long been the platform for innovation both in medical and surgical development in ophthalmology. Newer drugs and surgical techniques bring in new questions regarding efficacy, effectivity, cost, and all the different factors that interact in achieving the ultimate goal of preserving the patient's vision, one of the evidences of which is the Xen Stent. Now let's call back Dr. Mel as we begin this afternoon's Q&A. We'll be pulling up the questions on screen and we'll get to the questions. Okay, we're gonna pull up our first question, and okay, so our first question is the IOP lowering effect immediate, or is there a lag time from surgery to that reduction in IOP?
Thank you for this question. The IOP lowering effect is immediate. As soon as you deploy the stent, and as you saw earlier in the first video, in the traditional way of inserting it, a bleb can easily be appreciated. So the effect is immediate. There's no lag time whatsoever. As soon as you create that connection between the anterior chamber and the subconjunctival space, then no different from a trabe.
Yeah. Okay, so we'll pull up the next question. Thank you for that, sir. Our next question asks, How about for Muslim patients? Do you think they will allow their eye to receive a pig or porcine device? And how will you go about it? I guess explaining to the patient this procedure.
That's a very good question. That's one of the questions I asked Allergan before I started training to perform Xen implantation, and it's quite surprising that so long as it benefits their health, I think they can get some. I'm not a Muslim, obviously, but I think they can get some kind of dispensation from their church or from their mosque, or and I've asked colleagues from Singapore, who has a very large and healthy Muslim population, being adjacent to Malaysia, and there doesn't seem to be any issues with regards to having a partly porcine tissue device implanted inside of them, or inside their eye. Sorry.
Right. Okay, that's pretty
That
reassuring.
that was interesting. That was one of the first
Yeah.
questions I asked. Yeah.
Okay. Our next question is, we're just waiting for it to pull up on screen. Our third question is, doesn't the gel in the anterior chamber clog the Xen tube? And if it does, what can you do if the tube has been clogged by the gel?
Okay. Well, I don't doubt that the viscoelastic that we place inside the AC to stabilize it, if we're performing an ab internal approach. But I guess in a similar fashion, I mean, well, obviously, as you saw in the videos, we do our best to purge as much of the viscoelastic out. But, there's no way of knowing how much is left, and obviously that will enter through the 45 micron lumen. But in the same manner that perhaps after completing phaco, a bit of viscoelastic is left, and essentially the trabecular meshwork takes care of it. Remember,
Right.
remember that the Xen only takes up so little space, and you still have the rest of the trabecular meshwork left intact to filter out the remaining viscoelastic. Although, of course, the trabecular meshwork that they have is probably not as efficient as that of a normal person. Otherwise, they wouldn't have POAG in the first place. But no, it's never been an issue. And plus, we do prime the gel stent, or the Xen at the conclusion of the surgery. When you start injecting viscoelastic into the AC to purge the viscoelastic out, you'll also see a rise in the blood, which
Right.
means that
There's flow.
there's flow. There is
Right.
flow.
Okay, thank you, sir. Our next question, we can pull up our next question. Okay, what tips can you give to shorten the surgical learning curve? I presume this pertains to the ab interno approach. I presume most people who are starting will proceed with an ab interno approach.
The first tip that I would give to somebody who is trying to learn Xen is obviously to try to routinely perform intraoperative Cornea. Whenever we do phaco, we probably do it at about maybe anywhere from 8 to 10x worth of magnification. For Xen, for when injecting minimally invasive glaucoma devices, whether it be Xen or maybe an eye stent inject, we normally go up to about maybe 13 or 15x, and it takes a bit of getting used to using a Cornea mirror, placing it. Taking care not to press it too hard, otherwise you're going to get corneal striae. It's no different from doing Cornea in the clinic, obviously, but this time, since the chamber is pressurized with the viscoelastic, then striae are minimized. But the dexterity of your hands and the placing of the gonio mirror, whether you're using a Mori lens, a Catena disposable lens, or whatever, is crucial. That would be the first thing that I would advise surgeons to not only learn but master and be comfortable with. The second is that I would advise that for the first few cases, get eyes that are big. Don't get patients who have deep set eyes and high cheekbones, because you're gonna have a problem with that. Obviously, know your gonioscopic landmarks and be comfortable marking. Be comfortable in doing or placing the Xen temporarily if you're doing an ab internal approach. So as you know, Xen is not only used as a standalone procedure; it's also used in conjunction with phaco, similar to the eye stent. We call that the Xen combo. And whenever we do phaco, then and we make an incision temporally, then we enter the eye oblique, and the Xen ends up not at 12 o'clock, but slightly superonasal, which is fine.
Right.
Which is fine. So because remember, the inserter of the Xen does not bend. It's a very stiff gauge 27 stainless steel trocar. It will not bend. So as soon as you advance the inserter, it's the flange is going to hit the blade of the speculum. It's going to hit the high cheekbone, etc., etc.
Right.
So learn how to insert the Xen temporally or slightly inferotemporally, but definitely not at 5 o'clock.
All right. And in relation to that, would you recommend that physicians learning the Xen implant, should they first learn implanting the stent with their dominant hand? I mean, like, choose patients where they'd have to use their dominant hand first before transitioning to learning implanting that
Yes.
with the non-dominant hand.
That's very good advice, Nico. I did my first few cases, perhaps maybe the first 3 cases, using my right hand, implanting it on the right eye. But after that, it was like labo na. I could.
Okay.
I showed you a video earlier. Those are one of the early cases when I was using my left hand on the left eye.
Okay.
But really, if you're a fairly experienced cataract surgeon, it really shouldn't be a problem with dexterity. What's important is that you know the principles, you know the landmarks, and you know what? Perhaps one good advice is for you to like binge on YouTube videos, because they are all there.
Yeah.
All the complications, all the approaches, they're all there. It's like a freaking university, YouTube.
Yes. Okay, so with that, we'll move to our fourth question, or like our next question. So our next question is, do you have, okay, we'll wait for it to come up. Right. So do you have any pearls to share regarding performing Xen implantation, specifically in post-strab patients? And should you do primary needling first before injecting the Xen implant?
I think in patients who have undergone trabeculectomy, obviously we want that surgery to work at all costs, and we do our typical massage, we do our typical laser suture lysis, we do our typical needling, whether the sit lap or the operating room. But at the end of the day, there are patients that are absolutely resistant to all of these maneuvers. And before jumping into a tube, if the patient has an open angle and viable conjunctival real estate superonasally, then I would definitely go for Xen before entertaining putting a tube. As I've said, and I've often said this over and over again in all the MIGS lectures, minimally invasive glaucoma surgery offers another gear on your bike. The traditional
Mm-hmm.
way of treating patients or accelerating treatment in patients who remain uncontrolled or in whom surgery is perhaps maybe on the horizon is that we start off with meds and then we jump straight to a filtering procedure. But MIGS
Yeah.
gets into the way of that. So we can do medical management
Mm-hmm.
turn into MIGS because it really doesn't disrupt much. It's minimally invasive, especially if you don't
Right.
open cones. And then if all else fails, then you can perform a trab.
Mm-hmm.
So like I said, it adds so many gears on your bike. Instead of going from first gear to fifth gear, you have all of a sudden you have second gear, third gear, fourth gear, which is basically what SLT2 is, right?
Yeah.
It added another gear
Mm-hmm.
instead of adding another medication.
Mm-hmm.
You've got nothing to lose. Let's do an SLT if your angles are open. But I
Yeah.
will tell you this: in patients wherein surgery is necessary, and they can go either way because they're POAG anyway, the angles are open. I normally tell them, and I think as physicians, it's our obligation to let them know what their options are, right?
Right. Yeah.
And I'll normally write down on a piece of paper that you have two options. You either do trabeculectomy or we do MIGS.
Mm-hmm.
And then I ask them to go to YouTube and watch both. And then ask them to come back with a decision. And I guarantee you, Nico,
They'll choose MIGS.
10 out of 10 times, they will choose a Xen.
Right.
It is what it
Okay.
is.
Yeah. So we have two more questions. The next question is, with all your cases, how many would you consider to be a complete success? And I guess to snowball from that question, what are your parameters for success in a Xen? Are your expectations a bit um, more conservative than you would with the trabeculectomy?
Um, the Xen obviously is a very expensive device, which is probably why we're not putting as much as we should be.
Mm-hmm.
That's a given. As Norman Aquino would point it, why do Xen when you can perform trabeculectomy under a mango tree with pesos and cents?
Yeah.
I get it, but I tend to be because these patients are spending an arm and a leg for this device. I will do everything in my power to make sure that it succeeds.
Mm-hmm.
And obviously that's not always the case in all cases. Most of the cases are smooth, but as you saw earlier, revisions need to be performed every now and then. But with careful dissection, you can revive Xen, apply anti-fibrotic mitomycin C, and put a couple of wing sutures, and you're done.
Mm-hmm.
But if they're going to spend that much on a device, which in their minds promise everything except the moon, my standards are high. These
Mm-hmm.
patients need to be medication free. These patients should have very minimal astigmatism. These patients should not experience hypotony maculopathy, choroidals, and all those other things that typically complicate traditional trabeculectomy surgery. So, but of course, it's incumbent to us not to lie to them either, and basically
Right.
explain to them the efficacy of this device. And I don't know what your questions are coming after this, but a recent study was made comparing a 12-month success rate or 24-month success rate comparing Xen implantation and traditional trabeculectomy, and they're basically identical in terms of pressure
Mm-hmm.
and in terms of medication reduction or the absence thereof. In fact, they're so confident that they're starting to use it in pediatric glaucoma patients as well. So
Right.
things are evolving. While sleeping, a scientist in Israel is busy in his lab doing something, and it's just changed. Everything's changed. Before, we used to wait for textbooks to be published, the third edition, the fourth edition, which gives away my age, by the way. But nowadays, you can basically go on the internet and there are like 100 of new journals or studies that you need to read up on. So keeping up is quite a challenge for us.
Right.
But going back to your questions, no, my standards are high.
Right. Okay.
They're spending so much. They need to be okay, medication free as much as possible, and
Okay.
on target, and on
Right.
target.
So I guess we already answered our final question regarding the IOP lowering effect between MIGS and TRAB. Studies have shown that they are, well, success at least is comparable. Okay, and with that, yeah, yes, sir, you want to add?
No, I'm just saying that the studies, at least the recent studies that have, head to head, with similar preoperative IOPs, no washout, etc.,
Right.
same number of meds. There was no statistical advantage of one over the other. But the advantages of MIGS is quite clear, because obviously the post-operative course is basically a breeze, so long as it's been implanted properly. So go ahead and try it. Yeah.
Yes. So thank you, sir, for your for answering all our questions. I hope everybody was given more insight and was a bit enlightened by this emerging technique. If there are no other questions, we'd like to thank once again Dr. Romel for gracing us today. It was truly a pleasure to listen to your experience regarding the Xen Stent. We have now come to the last part of our program, which is actually a new segment in the TMC EyeTV. This is called the TMC EyeTV Bulletin, which will highlight events, happenings, and conferences in the world of ophthalmology. I would like to welcome one of our residents, Dr. Michelle Talusan, to give us a quick update on what to watch out for in the next few months.
Unmute siya.
So thank you for that introduction. So on behalf of the TMC Eye and Vision Institute, we'd like to thank you all for attending the first episode of EyeTV for this year. Now, exciting things are happening not just on our end, but there are more and more events happening all around the world. If you're interested in taking part in even more interactions with fellow colleagues, you should know that there are quite a few conferences in store. First, we've got the AAO annual meeting of 2022 happening in September 3 to October 3 in Chicago, Illinois. Next, we've got the World Cornea Congress in Chicago, Illinois for September 28 to 29. Next, we've got the American Society of Cataract and Refractive Surgery meeting in Washington, D.C. That's going to be in April 22 to April 26. Next, we've got the ARVO, the Association for Research and Vision in Ophthalmology annual meeting in Denver, Colorado, which is going to be in May 1 to May 5. Next, we've got the World Cornea Congress again, where the abstract submissions were actually last January 3, and the abstract submission deadline is actually next week. So get those papers in if you've still got anything up for submission. Early registration is on May 3, and the program preview will finally be available on July 31. Next, we've got the Retina World Congress, which is going to be in Fort Lauderdale, Florida, on May 12 to May 15. Another one, something more closer to home, we have something in Seoul, South Korea, which is going to be in June 10 to June 12. Next, we've got something in Milan, which is going to be at the Milano Convention Center in Italy, where the abstract submission deadline is also going to be next week on March 15. So get those papers in if you still haven't passed. So that's all we've got for now. Hoping to see you all soon here on EyeTV and maybe even in the conferences around the world.
Thank you for that, Mitch. As the pandemic wanes and the restrictions slowly ease out, it's really exciting to have the opportunity to learn and interact with our fellow ophthalmologists and industry partners through these conferences and fora. Again, please fill out the attendance sheet posted on the chat box of our YouTube link to have access to our previous episodes and to be informed of future episodes to come. We definitely have a lot in store for all of you this year. Once again, I'd like to thank Dr. Ramel Bautista for our very engaging, informative, and thought-provoking episode today. I would also like to thank our sponsor, Allergan, and of course, all our viewers for continuing to support us as we go 3 seasons strong. I am Dr. Nico Rogelio from the glaucoma section of the TMC Eye and Vision Institute, and thank you for tuning in to TMC EyeTV, Ophthalmic Instruction Without Borders. Good night.